Says it here. So we just recently realized that Christmas and New Year's are going to be on our usual presentation day. So we thought we'd just do a quick announcement. We'll also put it on a couple of other places, announcements where we'll not be doing the YouTube lives on Christmas or New Year's. We'll give you a break, but we will do something very quick for today. As you see, I'm taking off my cheater glasses, my readers. I shared something last week where I actually have a drusen. The good news was I don't need regular glasses anymore. The bad news is I have a druze. It's basically diabetic retinopathy. Is the bad one? No, it's just one as opposed to multiple. It's having no impact on my vision or my health right now. But it underlines the fact that as we get past 60, over half of us have insulin resistance. And that's by looking at very simple stuff, just an OGTT and a fasting glucose. In my case, I also have methylation problems. Neither one of those makes me unusual. Again, 60% of us age 60 and above have insulin resistance, and 40% of us have methylation problems. Both of those are risk factors for diabetic eye problems. So again, I'm just helping raise awareness, and we've got a lot of content coming out about that over the next few weeks. We'll also have a lot of content coming out about this obesity trends. The New England Journal just published an article December 19th of 2019, just a couple of days ago, showing the obesity trends predicted for 2030. Over half of us are projected to be obese by 2030. 50% of us with a BMI over 30. And 1 in 4, over 25% of us, a BMI over 35. That's classified as morbidly obese because it means it is having when you're that heavy, you have that much fat mass, it has a significant negative impact, which is not something that we just see metabolically. You see that at much lower rates. You see it grossly, I'm using some technical terms here. It has a big impact, very obvious impact. You don't have to get blood studies to find it. So let me, before we get into that discussion, Mr. YTLive, you do so much in terms of, in regard to your insulin. I'm surprised you have any problems with your eyes. That's the point. And actually, I'm glad you brought it up, and I'm glad I saw your point. By the time we have, you say, well, I'm not going to have a problem. I don't think I'm going to get full-blown diabetes. Most of us are not going to. By the time you get a diagnosis of full-blown diabetes, about a third of us already have diabetic retinopathy. There's plenty of science on that. I've got several videos on it. It depends on which study you're looking at. It's as low as 20%, but as high as 60 and some even 80%, showing that by the time you get a diagnosis of full-blown diabetes, you already have diabetic retinopathy. So before we get into this obesity discussion, brief obesity discussion, just a real quick repetition of the points. No YouTube Live this coming Wednesday, day after tomorrow. No YouTube Live January 1st, that Wednesday. We'll be back with YouTube Live on January 8th at our routine time, a regular time, 11 a.m. on the 8th, 11 a.m. Eastern time. Rob T07, hi Doc, Merry Christmas. So real briefly, let's just cover the projections. Do I believe them? I believe that the information, I mean, it's New England Journal. They did the projections very, very well. We'll talk about how they did them in just a minute, but I don't believe it. Here's why. Not because the technique was good. I'm an eternal optimist, and I think we're going to bend the curve. There's no question the curve clearly does indicate that by 2030, 48.9% of the adults will be obese, meaning a BMI over 30. And 24.2% will be severely obese, as in over 35. I think I got that number wrong. I thought both of them were higher because I was looking at Kentucky. This is a state-specific study, and you'll see that in a few minutes when I show you some of the details. The non-medical, non-science headline was half of US adults to be obese by 2030 and 1 in 4 severely obese. Here's the article itself, New England Journal, December 9th, 2019. Projected US state level prevalence of adult obesity and severe obesity, Ward and Associates. Special article, again, because this is a big, big deal. Now, here's a couple of the images that came out of the article. This is the prevalence by state of having a BMI greater than 30. That's obese. And once you get into, into orange, you're starting at about 30%. Blue is 60%. So you see some of this southeast Mississippi area, blue, over 60% of these individuals having a BMI of 30 or greater. In the next one, that starts out mostly green and goes to yellow and then some orange. This is BMI greater than 35. So as you see, again, capital of this obesity epidemic, Louisiana, Mississippi, Alabama. Here's another way of looking at it. This is looking at it by demographic breakdown. Overall, 21.4 having a BMI of 25 or less. Less than 30% having a BMI, 30% having a BMI of 30 or greater. Males, a little bit different distribution, but not that significant. Race and ethnic breakdown. The non-Hispanic blacks and Hispanics getting hit the hardest with 17.5 and 17% having a healthy weight. The rest of them, the rest of the demographic, obese. Annual household, again, this is a significant income-related issue. And here's the numbers down here for prevalence. So again, you see the breakdown. As you get poorer, you're more likely to have increased obesity. Let's just cover a couple of other things real quick. As I mentioned, I live in Lexington, Kentucky. So I looked at I looked at Kentucky. As we said, it's a statewide level. Over half obese and over 25%. 26% of males and 33% of females. BMI 35 or more. Now, how did they do that? Doesn't start to raise the question, how did they do this? Well, they looked at the behavior risk factor survey since 1993 and in Haines, the National Health and Nutrition Survey since 1990. The statistical methods I won't get into, but basically they were set up to help. Both of these studies are very, very good studies. And what they did, as you can see, they went back 3 decades from 2019 back to the 1990s, the 2000s, 2010s, and just continued the projections on growth. and both of these, neither one of these studies, the behavior risk factor study or in Haynes, neither one of them has had significant problems. They're very good. They're linked to the census, and they're very, very good picture of what's going on in terms of the health and nutrition of our country. Now, as I said, so why do I not believe it? Not because of the techniques. The techniques, the science was excellent in this article, as you'd expect from that journal. But I'm believing and hoping, at least, that we're going to bend this curve. How are we going to do that? Well, one of the things is I think the viewers of this channel are one of the groups that's early adopters. I think people are starting to get better understanding of what's going on in terms of our health and diet and the impact on our health. Especially on this channel, viewers are beginning to realize, look, knowledge of insulin resistance or prediabetes is critical. And if I can't metabolize carbs and they hurt me, I need to not be eating as much. As I've mentioned before, over half of my new patients, all my patients are coming from the channel now. Over half of them say, you know what, I've already lost over 30 pounds. It's clear from looking at the labs, the imaging, that there have been problems in the past, and that this individual is correcting those problems. The most common way is to say, well, look, doc, I've decreased my carbs. That decreased my hunger. I have gotten into intermittent fasting. And when somebody says that to me, what they usually mean on a practical basis is they've closed that window. In other words, they're not eating breakfast. They're skipping breakfast at this point. Some of them are going to one meal a day. I push doing water fasts. I don't get a lot of takers, but I do get a few takers on that. And if you're like me, one of the biggest issues is smaller portions. Despite the fact that I was doing 2 meals a day, low carbs, I mean, not two, yeah, 2 meals a day, 2 days a week of fasting, Monday and Tuesday, water fasts, I was still starting to gain weight again. I'd gotten back down into the low 50s, and I got back up into the mid 160s. And in terms of pounds. And that's just what I do. I come from a family with some bad history around food. My dad was my height, 5'10". And at one point in his life, he was over 350 pounds. So if I tend to hang around 150 to 160, as you can tell, my dad was more than 2 of me on the same frame. So here's the thing. We're starting to look at how can we help? What can we do? We're thinking about doing a pilot in terms of a webinar in this space. If we do that, it will be more of a participation type webinar, but we'll also be looking at the different types of impacts and focus that the science can have on healthy weight management. I'm going to go out of the show area and see what kind of comments that we have. So Kelly Lover, Mr. Tully, I learned through a cardio IQ test that I have a major problem with small, dense LDL. I think that eating mono unsaturated fats and avoiding saturated fats is part of what you have to do. Well, clearly we can show that. Bart Robinson, Merry Christmas to you and your family. Merry Christmas to you as well, Bart. Vic Guani, Doc, I want to ask about natural treatment for heart palpitation in WPW syndrome. WPW syndrome, by the way, folks, is Wolff Parkinson White. It's a little bit of a short circuit. Similar, it's got some similarities to what I have, atrial fib. Atrial fibrillation is the most common dysrhythmia that we have. And both of them have, again, a little bit of a short circuit in terms of our conduction cells within the heart that conduct the beat. Kofi Adega, hi Doc, I'm listening from Ghana in West Africa. Well, thank you very much, Kofi. Thank you for listening. I am not seeing a lot of other comments. Just wanted to get on very briefly, make you folks aware that we're not going to be doing a live event this coming Christmas the 25th or January 1st. If you don't have any other questions, any other comments, I'm going to go ahead and sign off. Now, Victor, I don't understand what specifically you wanted to talk about with Wolff Parkinson White. I didn't cover very much. Usually Wolff Parkinson's White, by the way, it's seen more often in women, more often in young women, and usually it's what we call benign or something that doesn't cause significant problems. Rob T07, hi doc, would you please explain what happens to a ruptured plaque when someone takes anticoagulants? How does the leakage of hot liquid plaque stop? Well, Rob, that's a really good question. Basically, the bottom line is that most people think that heart attacks and strokes occur when the artery just slowly closes off because the inside of the artery gets coated with plaque. That's not what happens. We actually, the artery tends to expand. The artery wall expands a little bit as plaque gets deposited. The other thing is that plaque doesn't get deposited totally on the inside of that artery lumen, or the hole where the blood flows. It gets deposited inside the artery wall. So what happens is this: our body will often attack that plaque. If it does, because it knows it shouldn't be there. And if it does attack it, that's what's called inflammation. And that makes the plaque soft, because our own immune system does what it always does when it finds stuff that shouldn't be there. It releases enzymes, and those enzymes are set up to digest and liquefy it. So all of that's working until that point, and that point is when that liquid plaque breaks off and goes out into the blood flow. How does it do that? The top of that plaque breaks off. It opens up and it leaks the hot liquid plaque into the bloodstream. When that happens, that plaque causes the blood to form a clot. If the clot's big enough, it goes to the heart. If it's big enough, it goes to the heart, it's a heart attack. If it's big enough and it goes to the brain, it's a stroke. Now, what happens when you have anticoagulants? Well, see, that's the point. Anticoagulants are given to help decrease risk for folks like myself who have increased risk of stroke because of atrial fib, some other things as well, recent post-stent, post-bypass graft. And so here's the thing, and that's what aspirin is for as well. Aspirin is technically not an anticoagulant, it's an antiplatelet. But antiplatelets and anticoagulants both are set there to decrease your probability of forming a clot. So again, the question was, what happens with an anticoagulant when you have release of hot liquid plaque? Well, then the hot liquid plaque is much less likely to form a clot. And again, it's the clot that kills you, not the plaque. So good question. Thank you very much. Mr. YTLive, question, do you use LDL A versus B pattern? Oh, yeah. Do we use LDL A versus B pattern in tests? I don't think you have done a video on this. You're right. I'm impressed. 700 and almost 800 videos at this point. And I don't have any videos on A pattern versus B pattern. However, I do discuss it on almost every one of our patient views. Let me go and see if I can find that. It would be an interesting thing to show if I do. Just bear with me just a second. Well, Maybe I'm going to be able to make that work. Maybe not. What I was going to do is go into my chart on the, for some reason, I was going to go into my chart on the, here we go. So I should have that in here, and it's an interesting concept. I'm glad you brought it up. And let's see if I can find. And we'll do a new share so you can see this. Okay, you should be able to see my my blood studies right before the last Louisville event. You see hemoglobin A1C, insulin, glucose. Here is LDL. As you see here, I have an LDL-B pattern. What that's talking about is this. We're talking about total lipoprotein mass and diameter. So this is HDL, that's LDL, and this is the mass versus diameter patterns. As you see, a bell curve here for HDL and a bell curve here for LDL. Now, you see below here, this is basically showing that the larger HDL is better, it's more effective, and my peak is down here. So my HDL is not the best in terms of profile and size. Same thing with LDL. We want the peak of that that bell curve to be right over that large green LDL. Now, what do you do for that? You do basically the same things that you do to manage the rest of the LDL and HDL patterns. So as you can see here, my HDL large is not prevalent enough, and I could use a little bit. I'd be better off with a larger population of LDL. These numbers, by the way, when you go back and look at my things like triglyceride over HDL pattern, I've had significant improvements in those. As you see here, my triglyceride over HDL pattern is less than 1. It's almost a half. Now, why do I jump over into that? Here's the reason. If you look at this lipid subclass that you mentioned, I think it was Mr. Tully. The best way to impact those is, again, as I said, improve your insulin resistance situation and some other things like that. So, Sebastian Pesci, hey doc, can you tell us what to think about in terms of the use of modafinil? I am not familiar with modafinil. If you would send us some information on it, I'd be very interested to take a look. And Mr. YTLive, thank you, Kelly. Not sure what that means. Rob TO7, so how does a ruptured open plaque heal, or doesn't it? Well, again, it's not so much the issue of healing a ruptured plaque. It's an issue of when that plaque does rupture, if it is liquid, and usually a plaque that ruptures is going to have a liquid core, not allowing that liquid core to form a clot. C. Lear, can keto affect GFR? I believe you're talking about glomerular filtration right there. In other words, that's our kidney function, to maybe interpret for some of the rest of us. Or the supplements you can take affect GFR. I did weigh 211 pounds, now weigh 162 pounds and 5'11". GFR went from 86 to 56 to 51 in the last year after starting keto. Yeah, it's interesting. You can see some changes in filtration rate. One of the first things to do is not panic. You do want to have a nice, healthy filtration rate up around as high as you can. 86 is obviously a great number. A drop from 86 to 56 is obviously not good. I am not aware of keto itself or any supplements having a significant impact on it. I saw a patient recently, and it looked like she had had that about a year before she came to see me. One of the biggest concerns that you have is, okay, is there a did that person have an infarct in their kidney or some atherosclerotic changes of the that renal artery, the artery to the kidney. Thank you again for your interest. We didn't want to do a full-blown video today. We just wanted to do some announcements, say hello to some folks, and let me just ask you, if you're interested in taking a little bit deeper look at your at weight management, healthy weight management, let me just do this real quick. If you'd be interested in getting a little bit deeper into healthy weight management with us in the future, please let us know. Clyde and I are discussing how to get that into our set of priorities and how to get something set up for that for the new year. Because again, there are very few things that our population can do that for our health that's more important than managing that BMI. Now, a viewer recently said, Brewer, why do you keep talking about BMI? It's fat mass, isn't it? Yes, it is fat mass. So if your BMI is 30 and you look like Arnold Schwarzenegger did in 1970 when he won Mr. Olympia, then you're okay with a BMI that high. But very few of us look like that. It's body fat mass. We used to think that fat was an inert storage tissue. It's not. It is a very active, very aggressive, very dangerous endocrine tissue. It secretes leptins and adipokines and some things that have a big impact on our body. Some good, but mostly bad. So thank you again for your interest, and please let us know. Send us an email, comment on our channel, send us your email address. Let us know that you'd be interested, if you would, regarding weight management. Thank you for your interest. And Merry Christmas. Happy Hanukkah. I think there's Kwanzaa. I think there are a couple of other things as well. Have some happy holidays. Talk to you later.